Informed consent. Documentation of informed consent may provide a powerful defense to any lawsuit. Informed consent is the process of giving the patient information needed to make educated decisions regarding their healthcare treatment. Informed consent serves as an opening for dialogue with the patient, provides them with an opportunity to ask questions, and involves them in your care. The basic principle of informed consent is a competent person has the right to choose what will be done to them. Simply put, when there's risk of harm from treatment being proposed, providers have a responsibility to ensure the risk is disclosed, understood, and accepted by the patient. It is the responsibility of the provider to inform the patient of the treatment procedures and to receive the patient's informed consent to proceed with those treatments. If the patient is a minor or an incompetent adult, the informed consent decision or discussion should be include the patient or the legal guardian as well. Consent cannot be considered informed unless, at a minimum, the physician orally explains the risk associated with the proposed course of treatment, answers any questions the patient may have, and obtains the patient's permission to treat. And the discussion should include the risks and benefits of treatment, alternatives to treatment, and the discussion should include a review of likely outcomes if the treatment is withheld or refused. So H&S best practice for informed consent is we are legally and ethically obligated to obtain informed consent from our patients prior to initiating treatment. And during ongoing treatment, the patient may present with a new condition or an additional condition that was not addressed when the initial informed consent was obtained. Providers should obtain new informed consent when presented with a new condition that was not addressed with the previous informed consent was obtained. Tough thing to do. You're going along, they've got a low back problem. They come in, they've got a shoulder and neck problem. You've got to update that informed consent. It's a different condition, different set of concerns for adjusting somebody's cervical spine versus their low back. Again, I think that's one thing. It's harder to do because it doesn't follow kind of the rhythm of your practice, but it's an important thing to do. And quite frankly, do you find informed consent to be a difficult thing to get in your office? No, it goes pretty smoothly. Yeah, absolutely. And while a form cannot replace the required face-to-face discussion between the doctor and patient, H&S requires written evidence of the clinical record. In the clinical record, the provider obtained informed consent from each patient prior to initiating treatment. And the record must include the signed and dated H&S informed consent form or other form. The H&S form, of course, is on the website. Okay. Any questions about informed consent? Nothing? All right. This is another topic. Another topic that we'd spend an hour on. Yes? So the question is, if you have a patient going over a Spanish informed consent, and there's an English speaking. Okay, yeah. Because you speak Spanish. No se habla. Okay. So you're going over that, so you're speaking in English. They have it in Spanish. You know what's on the form in Spanish. As long as you are communicating them, the risks, the alternatives, and so forth, answering their questions, I think that's what you're trying to do. So you'd have them sign that form, and then you'd put that in your note that you had a discussion, and go right ahead and put in there the patient is primarily a Spanish-speaking patient, and we went over a form that was in their native language. So, I don't think it needs to be a big deal. All right, well, let's move on to professional boundaries. Sexual misconduct allegations are becoming more and more prevalent among chiropractic profession. Unfortunately, while some allegations may be justifiable, often they are based on a misunderstanding or even malice rather than on a doctor's actual behavior. Before you can defend yourself regarding this somewhat ambiguous concept, we need to understand what boundaries are. Boundaries are mutually understood, unspoken physical and emotional limits of the relationship between the patient and the doctor. So the ACA statement on sexual intimacies with the patient are as such. In response to numerous requests for clarification relative to the ethical implications of sexual intimacies between a doctor of chiropractic and a patient he or she is treating, the ACA Ethics Committee issued the following advisory opinion in 1991. I'll go to that. The physician-patient relationship requires that the doctor of chiropractic to exercise utmost care that he or she will do nothing to exploit the trust and dependency of the patient. Doctors of chiropractic should make every effort to avoid dual relationships that could impair their professional judgment or risk the possibility of exploiting the confidence placed in them by a patient. So minimizing that risk, as most seasoned doctors are clearly aware, there are situations in which patients initiate improper behavior and time in which a doctor may inadvertently behave in a manner which could give rise to a lawsuit. So these following steps can help to reduce that. Number one, identifying the high-risk patient. The flirtatious patient, a predatory patient, or patients with unrealistic expectations or perceptions of the doctor. So I will tell you, being on the board, I'm going to choose my words very carefully because I get myself into trouble every time I talk about this. But there are patients that are looking to cause trouble. They come into your office. They are there to cause trouble. There's a difference between, my 75-year-old patient that brings in tomatoes and zucchinis and things like that, and they want to give me a hug or on my birthday or something, but it's the patients that are inappropriately. I mean, you can tell the difference in those patients. So while it is a very intimate thing we do in adjusting patients and having hands-on patients, I find it pretty easy to make sure you don't cross that boundary with the patient. We talked a little bit about younger patients, teenagers, whether they be teenagers or younger women, and how to be very careful with that. They're dressed in a variety of different ways that they can expose themselves, shall we say, and maybe by accident, but just how you handle that is important. So we treat our patients in a very efficient manner, a very respectful way, and I find not lingering with the patient or not discussing personal things with them. What'd you do this weekend? Or was it a good concert? Yada, yada, yada. Keeping it as professional as you can. So there are a lot of different things you can do. But preparing for that high-risk patient means by being prepared and establishing your personal policy in advance, you can avoid being caught off guard, thus avoiding some awkward and potentially risky situations. Here are some ways you can get ready for situations you must establish control. Train your staff. Let your staff know if you open the door. There are times when I've asked, if I open the door and I say, Gabby, I don't have to go out and explain anything to Gabby. Gabby knows if I open the door and say, Gabby, she comes back to my office. And that could be for a variety of things. So again, that's a training thing you do with your staff. It could be she's helping me with the patient. It could be an awkward situation like this. Listen to your staff even if it goes against your ego. Most of us have female staff. I would suggest you listen to them. That's very important. Check with past doctors. If that patient has gone from doctor to doctor, that is not a bad thing to do. Understand diversity within cultures and how this affects sexual boundaries. We were having dinner last night, and Dr. Outen, who's over in Cary, was talking about he's got some Muslim patients, and they're very devout, and so the wife was going to be examined by the doctor, and the husband wanted to know exactly what was going to be done. And so that was good that Dr. Outen was willing to take the time to communicate with the husband. It was important to them, important to the wife, and of course they've been a patient for a long time. I think it was Dr. Ayers was talking about, he had another patient that had a particular religious belief that the female could not shake the hand, Dr. Ayers' hand, when she presented into the office. So again, those are respectful things you need to be wary of. So they're not necessarily just sexual boundaries, but just social boundaries as well. Appropriate and effective communications. and watch for signs of patient discomfort. We want to be real careful how we're talking about things. Perform all initial exams whenever possible during normal business hours and only when employees are present in the office, and explain the types of treatments you're going to perform. Use exam gowns when necessary and drape for privacy. Consider a CA or having a chaperone present when treating members of the opposite sex, and have a parent guardian of the same gender supervise when treating a minor. Welcome the parents into the office. Please come back into the office. Have them come in to the exam room while they're being examined, especially if it's a daughter and the mother are there. I encourage them to be in the room together. It just makes it easier. I know I've even had situations where I've gone to examine or treat a patient that had PTSD type symptoms and had a very interesting reaction to me adjusting them. And so how we handle that, I always try to, in that situation, I would get the staff in. I prefer it if they have a family member there, but certainly bring my staff in and then just engage having that second person in there. This is the thing. I don't not want to treat those patients because those patients need chiropractic care. Those people need to be in our offices. You just got to learn to be comfortable with that and deal with that. So, okay? Any other thoughts? Good. Whew. I made it through that without getting into too much trouble. All right. Patient noncompliance is a powerful legal defense. There's little doubt to any practicing physician that patient noncompliance is a significant and contributory factor in poor outcomes and potential malpractice claims. There's little doubt that patient noncompliance can lead to a more aggressive and costly treatment. What you may know is what you may not know is the extent to which the patient's noncompliance can increase your risk for a malpractice claim and just how much good documentation can protect you. While it is reasonable for you to expect the patient to share in the responsibility for their own care, juries nationwide have placed a significant amount of responsibility for follow-up on the provider. When patients fail to follow treatment advice, it is prudent to document this in the healthcare record. There are compelling reasons for providers to document patient noncompliance. If such noncompliance contributes to an injury which results in a malpractice suit, it can usually be introduced as evidence in the doctor's defense. Documentation of patient noncompliance may provide a powerful defense to any lawsuit. Depending on the state law, a plaintiff's recovery may be reduced or prohibited based on the percentage of fault attributed to the plaintiff. That's a pretty strong statement. It is important to recognize the difference between noncompliance and the patient's right to refuse care. Patients have the right to make informed decisions regarding their care, including being informed of their health status, being involved in the care planning and treatment, and being able to request or refuse treatment. So noncompliance can be the result of an educated, rational, and reasonable decision on the patient's part to exercise control over their own health. The medical record should include documentation that the diagnosis and proposed procedure treatments were explained to the patient and that the explanation included the patient's prognosis without the procedure, the risk and benefits, and alternative therapies. So, suggestions to enhance patients' compliance: emphasize the seriousness of any recommended imaging studies. This x-ray thing is interesting. While there are a lot of us that don't want to be told that we can't take x-rays, there's a lot of people that don't take any x-rays. And, just being careful how you make those compliance. But there are some patients that don't want to take x-rays because they don't want to pay for them. So you've got to make a decision whether you're going to accept the patient if they're going to refuse, whether it's x-rays or any type of diagnostic procedure that you think should be important. Explain the rationale for your treatment advice. Allow the patient to voice any concerns they have about recommended treatments. Attempt to gain agreement on the treatment plan, and emphasize the importance of adhering to the treatment plan as well. So document noncompliance. When the patient has failed to comply with your recommendations, document the noncompliance, avoiding any documentation that may look judgmental or self-serving. Among the most common problem areas are repeated failure to keep appointments, This is documented in our EHR. We can run a report on the patient and it shows all the missed appointments. Failure to have diagnostic studies or consultations with other healthcare professionals as recommended. And of course, H&S has a non-compliance form that is on the website that you can use as well. Just lots of great resources on there, okay? So we were talking about this yesterday with Dr. Clements and talking about patient compliance. It's very important to me. So my staff understands that if I want to see a patient on Monday, Tuesday, and Thursday, I want to see them on Monday, Tuesday, and Thursday. I don't want to see them on Monday, Wednesday, and Thursday, or Monday and Wednesday, or Tuesday and Thursday. I want to see them Monday, Tuesday, and Thursday. Now I realize there are real things that happen that affect that care. Somebody gets sick, somebody has to go pick up a child, but the most important thing between me and that patient is getting good quality chiropractic care. So my staff, if somebody calls to cancel an appointment, will absolutely, if it's early enough in the day, they'll say, what time? They won't say, okay, what time this afternoon can we reschedule this appointment? And if they can't make it in that day, what time tomorrow can we make up this appointment? So we intentionally use words that keep patients focused on being consistent with their care. So those are important things to do. Probably a lot of different things. And again, my whole philosophy of care is if you're taking care of the patients in a responsible way, documenting everything and making good clinical judgments, the money takes care of itself. So we don't do it for the money, we do it for the patients, and the money just walks in with that. So here's the non-compliance form. You can look at this. So another thing, maintain a reliable tracking system. Without a reliable tracking system, it may be difficult to identify patients who fall or who fail to keep scheduled appointments. If the patient refuses studies, recommended care, etc., document it. So put it in there. Failure to maintain a reliable tracking system is one of the most frequently cited problems in malpractice cases where there is an allegation of delay in diagnosis and or failure to supervise care. So you all have, well, most of you have some type of a smartphone, and there's a calendar in that, but I don't know that I would want to keep all my clinical information there. We use Outlook in our office and the staff. You can use any calendar system, scheduling system that you want for stuff like this. So anything that needs to be accomplished in our office is in our in-office calendar. So we've got a system of how we call patients. But then we can put as reminders a week from now, call Mrs. Smith, MRI to get the MRI report or whatever it might be. We're going to do that. So we like to keep track of those. So have some kind of a tracking system that you can go back, and if you needed to copy off those reminders, you could do that as well. Who has a good tracking system for this? Give me another idea. Anybody? Nobody? How do you keep up with this kind of stuff in your office? You have a recall log through ChiroTouch. So if you referred somebody out to get an MRI and you don't have a scheduled appointment after that, how would you keep track of that patient?
They fall out. It doesn't automatically fall on to the fall off because they don't have another scheduled appointment. We can actually manually put it in there, follow up with so-and-so for MRI.
Excellent. Excellent. That's a good thing. Anything else? Any other ideas? Maybe you have some type of written report. Maybe you write it on your calendar. And don't tell me that Post-it note system's not your system, okay? Some of you CAs have like 59 Post-it notes across the back of the... You do, huh? No? No. She's got it together. So anyways, have some kind of system. If you don't have a system, that's a big red circle around that one today. Okay? And coordinate treatment plans with other providers involved in the patient's care. Maintain good communication with other providers involved in the patient's care and maintain a clear understanding of the expectations and the role of patient's plan of care. Let me pause here for a minute. You talk about an important thing. It is very important. But the neurologist that I use in town, he's a great guy and a great neurologist, but what I like most about him is within the calendar day of my patient being seen in his office, I have a full report already sent to my office. That is helpful, especially with someone like that. I'm getting my MRIs reports within 24 hours, any other imaging within 24 hours. That's what I want. So let's turn things around. Physician refers patients into you. The best thing for you to do is get that record back to the physician who referred that patient with you. Again, there's a purpose. You want to communicate. They want good continuity and coordination of care. It's a good thing for you. It's a good thing for me. So when the patient fails to follow recommended advice and a poor outcome results in a malpractice claim, objective documentation of noncompliance can be your most powerful defense. Another time I'm seeing a lot of this is with the VA patients that are now being referred to our office. We're getting a fax the day after their scheduled appointment to let them know if the patient made it in for the appointment. So that's pretty specific. So let's talk about discharging a patient. Occasionally you may encounter patients who no longer wish to treat. Reasons for ending the physician-patient relationship are many and may include chronic noncompliance, rudeness in the office, to the office staff, or non-payment of bills. Why these patient behaviors can affect the interactive care giving process, they may also identify patients with the propensity to file a claim against you. To help reduce the risk of a future claim, a physician may terminate or discharge a patient from the practice. There are, however, certain exceptions that apply to terminating a patient. You may not terminate your professional relationship for any discriminatory purpose or in violation of any laws or rules prohibiting discrimination against Americans with Disabilities Act. You also are not permitted to terminate a patient where you know or reasonably should know that no other healthcare provider is currently able to provide the patient the type of care or services that you are providing to the patient. So to reduce the risk of abandonment with that patient, abandonment occurs when a physician suddenly terminates a patient relationship without giving a patient significant time to locate another practitioner. This is another thing that comes across the board desk. Patient's not paying their bills, staff kicks the patient out of the office. All right, you got to pay your bills, you got to go. So you want to avoid that. That's a staff training issue. A patient, however, may withdraw from a physician's care at any time without notifying the physician. To reduce the risk of allegations of abandonment, it is recommended that you discuss with the patient in person the difficulties in the physician-patient relationship and your intention to discharge the patient from the practice. It's a tough conversation. Be sure to document the discussion fully in the patient's medical record, also noting the presence of any witnesses such as patient's family member or a member of your staff. And then write a formal discharge letter to the patient. You are required to notify the patient in writing of the termination. The letter must state that you no longer provide care to the patient as of a date, certain date, and the date should be at least 30 days from the date of the letter. You must also state in the letter that you will be available to provide emergency care or services during that 30-day notice period. A description of any urgent medical problems the patient may have, and an offer to forward copies of the patient's medical records to the subsequent treating physician, and the name and phone number of a local physician referral service to assist the patient in locating a physician who's accepting new patients. Okay? So you send all these patients to the chiropractor you don't like. I'm just kidding. No. We all like one another. Last thing is the care of a patient is a mutual agreement between you and the patient, but when that relationship is strained, you can no longer feel that you're able to provide quality care to the patient. At that point, it's time to end that patient-provider interaction. So make sure you have attempted all you can do to help with, and when you realize that there's no more to do, discharging the patient may be the only course of action. So steps, this is out of medical economics. Take the proper steps to discharge the patient. Put your dismissal policy in writing and practice it consistently. That's exactly how we do all your policies, being consistent. Make sure your staff members understand that. Check your insurance carrier contract regarding discharge and inquire about any responsibilities you may have to the process. You're listening to it right now. Check your responsibilities to your malpractice insurance carrier. State your reasons for dismissal in the letter to the patient. Be as objective as you can and give that 30-day window for the patient. And send the discharge letter to the patient. via both regular and certified mail. Be sure to keep all documentation of that conversation. If the certified letter is returned undeliverable, mark the return date on the envelope and attach the letter in the envelope to the patient's chart. Once a termination letter is sent via certified mail to a patient who has moved and left no forwarding address, or to a patient who has refused to accept the letter, you are no longer responsible for the patient's care. And also, always offer to send medical records to the patient's new physician. Okay? Should a patient subsequently request medical attention from you, agree to treat the patient only if the situation is a genuine emergency. And if it's not an emergency, then inform the patient diplomatically but firmly that their physician-patient relationship is damaged. Refer to the patient the letter to the previously sent letter, and indicate a willingness to find the patient another doctor and transfer their records to that doctor. And again, just documenting all those steps with that. Okay? So, situation that I would say last time I had to do this is and I've had this to happen a few times, is I've had patients try to be inappropriate with my staff. That's probably the number one reason I've had to get rid of patients. And we just don't put up with that in the office. So we take care of that pretty quickly.
How did they know?
They were dumbfounded. But if you want to have good staff, you got to treat them like that. So yeah, that's why they're around for 8 or 9 years at a time. Treat them well and pay them well. So yeah, and it worked out well. Of course, the guy was he was embarrassed. He just crossed a significant boundary with the staff. So in that situation, I let him go immediately. So, but we had to go through all these steps with him. Okay. Any other questions? So Dick Armstrong's never been able to come back into my office since. Excuse me. Oh, I didn't realize he was still here. No. Okay, malpractice coverage. We're kind of winding things up here. Just hang here with me. Malpractice coverage. This is an exciting topic. At all times, H&S providers are required to maintain professional liability insurance with minimum coverage of $1 to $3 million. And all providers should contact their malpractice carrier immediately if they suspect a patient may be contemplating a malpractice action. Now, I will tell you this because I've heard this many times, is if you get a little embarrassed if somebody starts questioning your care or there's a situation, you certainly become uncomfortable. But this is what malpractice insurance is all about. They will handle you and tell you exactly what you should or should not be doing in that circumstance. So, had one situation, I can't even remember it. I went ahead, it was kind of an awkward situation. It wasn't a malpractice thing, but it was an awkward thing with the patient. I called my malpractice carrier, NCMIC, and she told me exactly what I should do and not do, and it played out just fine. So that worked out great. All right? So, closing thoughts. Make this year a better year. Make this your big year. A game plan for success. Okay? Number 1, take the time to review your notes within 7 days of this seminar. It's great. You'll leave here. You're a little tired now. You are high on donuts and brownies, thank you, and your Coke that you had at lunch and the cookie you had at lunch. So you're a little tired at this point, but make sure you follow up with these notes. This is an important seminar, and it adds a lot of value to what you do. Schedule time to sit down and add templates, forms, and content into that EHR system. Those doctors that will invest the time to organize things and put things together in your EHR can then provide better quality notes in a much more efficient manner. Okay? I have spent a great deal of time organizing my notes, and it's a constant process. I'm adding things new into my notes, certainly every month. I wouldn't say every week, but every month. I will go back after today and this week and maybe make a few changes into my note system this next week. Would you agree? Constant. It's very fluid. Number 3, do a self-audit using the H&S audit form. That's a form that is on the website. Go through one of your notes. Just go back, have your staff pull out one of your notes, do a self-audit, and see how it looks. This thing, your notes aren't going to be as good today as they will be 3 months from now. If they're not changing, they're not improving. So we want you to be a better note taker, better documenter 3 months from now than you are today. Review your ICD-10 coding. Start using more codes. I think this is a big deal. I think ICD-10 coding, I think we all kind of got over the hump on that, the scare, and then we put all that stuff away. But if you're not using, and when I'm talking multiple codes with each patient, it wouldn't be unusual for me to have a dozen ICD-10 codes on most of my patients. It's because we're looking a little deeper into that, and the back side of that is providing more information to the carriers, and it's very important. Number 5, invest in staff training this year. Ladies, maybe a few gentlemen, but staff, you need more time. You need to learn more. I love the situation where the staff member's been working. I've been working in chiropractic for 25 years, but I haven't been to a seminar in 20. Well, you can't possibly keep up with this stuff on your own. So take your staff to an NCCA seminar, pay the money, maybe a Parker seminar, whatever it might be, but continuing education. And let me tell you, there's so many webinars that are free or low cost. Make sure you're letting your staff know about those and keeping them educated. There's opportunities on the website as well. And regularly check the H&S website to see changes and added resources that are available to you as well. All right, any last questions that you may have? I'm happy to answer any question. Dr. and Ms. Bender are here. We've got the board over here. Dr. Sarah Gusa knows everything. Any questions? Well, great. Well, listen, I have enjoyed this so much today. Thank you very much for being here. We'll see you next time.